Well, hi everybody. Welcome to the session on familial and genetic associated pulmonary hypertension, question and answer and presentation. My name is Eric Austin. I'll be chairing the session today. I'm a physician and physician researcher at Vanderbilt University in Nashville. I'm actually a pediatric pulmonary hypertension doctor, but I do research with really all of the people on this panel. Have worked closely with at intermittent times on all forms of all types of ages of pulmonary hypertension. And it's my honor to introduce you to the three esteemed panelists that we have, or perhaps I'll let them each introduce themselves since they can do it even better than I can, starting with Micheala, please. Dr. Aldred.
Hi, everyone. I'm Micheala Aldred. I'm a researcher in genetics at the Cleveland Clinic, and some of you have probably already seen me in the research room over the last couple of days.
I'm Greg Elliott. I'm a pulmonary physician who's worked with pulmonary hypertension since 1981 in Salt Lake City. I'm at Intermountain Medical Center where I do both patient care and research related to heritability of pulmonary hypertension, along with other colleagues. None of us do this alone. I think Eric made that point.
Hi, everybody. My name is Lisa Wheeler. Some of you probably already know me, but I work with Dr. Austin at Vanderbilt University Medical Center. I am a research coordinator, not a physician or a nurse. I just sort of fell into this by accident and love it. Been there for 22 years, coordinating research with patients who have a familial history. So it's been a lot of fun, and I hope to get to talk to all of you before the day is out.
So we're blessed to have this really impressive panel. Dr. Elliott and Lisa have been involved in pediatric research with regard to search for genetic variations or mutations for many years, as you heard, as has Dr. Micheala Aldred, who's one of the leaders in the science around the variations that may cause or contribute to pulmonary hypertension. The way we decided to set this up, if it's okay, was to each have about a 6 to 7 minute discussion of some key topics that we think are important, but then leave many minutes for questions and answers. So we will hopefully get to all of your questions. Certainly I'm happy to stay after if we run long. We're going to try and move through the sort of presentation part and then go to questions, but please don't hesitate to interrupt us, to ask us questions, or to bring us popsicles or anything. We'd be thrilled for any of that. Michael, did you bring one for everyone? You know the rule. All right, we'll let it slide this time. Okay, so I'm going to introduce just a few concepts around genetics and genes, because that is something to lay the groundwork. So as you know, pulmonary hypertension can occur for a variety of forms and a variety of subtypes, and you probably know that from your own experience, and you've seen that here this weekend at this wonderful conference. Pulmonary arterial hypertension is a particular type of hypertension that has been most closely associated with the identification of the ability for that disease to be either transmitted from someone, so you receive it as something you can inherit, or to be in families for a reason we don't understand. If an individual has 2 or more people in their family who have pulmonary arterial hypertension diagnosed, by definition, we consider that to be familial pulmonary arterial hypertension, also known as heritable or heritable, depending on the word you like to use. So that means it can be inherited from someone, a parent, or it is heritable. It can be received and inherited from a family member. And what you're really talking about is inheriting a risk of developing the disease, not necessarily automatically developing the disease. There are some people who have pulmonary arterial hypertension, and they're the only person in their family that we know has it, despite great efforts, and Lisa has done this for years, trying to find individuals and families who may have had pulmonary arterial hypertension in addition to the initial person that we met. But there's some families where we never find an additional person, or we don't currently, but that does not mean it is absolutely not a disease that can be inherited. It still can be inherited. So for a minority of individuals, they, for whatever reason, developed a variation in their DNA that led for them to get pulmonary arterial hypertension, and even though no one else ever had that variation before, it occurred spontaneously or it was inherited from someone before they died, it still is a heritable disease, so it still could be moved forward, passed forward. We'll talk a little bit more about that in a few minutes with Dr. Elliott, but I just wanted to lay the groundwork of heritable means something that can be passed on to your children. or runs in the family. Familial PAH insinuates that there is 2 or more people in the family. We may not know why they've developed the disease, but we think that they share a common variation of their DNA probably that puts them to susceptibility. Your DNA is the building block of all of what makes us unique. So you all may be familiar with the term DNA. DNA is the characteristics in our, the substance in our cells that creates the characteristics that make all of us who we are. Our DNA is made up of many things, but one of it is about 22,000 different genes. A gene is a very small piece of DNA that directs information to make what's called a protein. You may remember from biology the concept of DNA to RNA to protein. And protein is what acts in cells to help it have its characteristic and helps the body come together to have a characteristic way about it. Everyone theoretically has 2 copies of every gene. You get 1 copy from one parent and 1 copy from another in the, quote, normal situation. So, for example, shown here is a parent, either a mother or a father. That person has 2 copies of all of those 22,000 genes. One of those copies is going to be given to a child in combination with 1 copy from the other parent. So when a mother and a father have a progeny or have a child, they share 1 copy of their gene, and they share 1 copy of their gene. And you can either get, in this case, I drew an example of a person who has, say, perhaps what if they have familial pulmonary arterial hypertension due to a known gene variation or mutation. Blue would be, quote, the normal gene, red would be the abnormal gene, and in this case, the child got 1 normal blue gene from mom and 1 abnormal red gene from dad. That's called inheritance. You have inherited a genetic a gene, which creates you to have the opportunity that you would have a genetic abnormality or variation from normal. Mutation refers to a variation in one of those genes that is extremely rare in the population. A mutation is really just a variation from normal in a gene. And we figure out normal by studying millions of people and deciding what is the typical gene structure for a population of individuals. If you have a gene that is abnormal from the typical population, then we think of it as being a variation. And that variation can be a common variation that we see in many people, maybe 10, 20, 30% of the population has this variation, or it can be exceptionally rare, less than 1% of a population, less than 1 in 100 people. And that would be considered a mutation. The variations in the DNA that we know to strongly associate and probably cause pulmonary arterial hypertension that you're going to talk about today are mutations in the sense that they're exceedingly rare. A person who does not have pulmonary arterial hypertension would be incredibly unlikely to have that mutation in that gene. The last word that I wanted to touch on before we go into our presenters' discussions is this concept of reduced or incomplete penetrance. Reduced and incomplete are essentially the same term here. And what this is referring to is the fact that, remember I mentioned we have about 22,000 genes. In pulmonary arterial hypertension that is inherited, usually there is 1 gene in particular that we think is essentially causing the individual to get disease. In that case, it would be represented here. You have 1 normal gene, it's called an allele, 1 normal gene copy, and 1 abnormal gene copy. And that naughty abnormal gene copy, we think, promotes the condition of pulmonary hypertension. However, there are people who walk around like this parent, totally healthy, and never develop pulmonary hypertension in their lifetime. We don't necessarily know why that is the case, why they're fortunate not to develop pulmonary hypertension, but what we do know is that that leaves them with a condition that is reduced penetrance or incomplete penetrance. We know that this genetic risk factor is not completely penetrant. Not every person with a pulmonary hypertension gene mutation will develop pulmonary hypertension in their lifetime. And that's wonderful for that person, but it does still mean that that person could have family members who are at risk of inheriting that gene and developing pulmonary hypertension themselves. So the concept of reduced or incomplete penetrance is to suggest that a person may have a mutation in an important gene but never get sick. And everyone in this room has many mutations in genes that thankfully never cause disease. We don't totally understand that yet at the scientific level, but it is a known condition, and we know that to happen in pulmonary arterial hypertension. So does anyone have any questions about the background discussion of genes and genetics before we talk more specifically to pulmonary arterial hypertension? Please don't hesitate to ask questions. I think Dr. Oh, yes, ma'am. We do, and Dr. Elliott, I believe, is going to discuss that next about the specific locations on the DNA chain that have coordinates for genes. So, just to reiterate, the DNA is this huge, long collection of genes, and there's about 22,000 human genes that we know of, and there are several, about 8, that are thought to be naughty and maybe cause pulmonary arterial hypertension. So now, if it's okay, Dr. Elliott, we'll have you open the discussion regarding pulmonary arterial hypertension and its genetics.
Eric, thanks very much, and really thanks to all of you for coming and your attention. I'm going to do this a little bit like I do sometimes with patients the first time I speak with them about genetics and genetic testing. So I'm going to use Eric's discussion, but I'm going to say to you that your genome is like a book, if I can make an analogy that I think is understandable. And you would recognize that a book has multiple chapters. We'll make it 46 chapters for the chromosomes, right? And each of the chapters has sentences which are instructions, some of those sentences, to build something. And what it's building is proteins that make your body function and do things. So simply stated, mutations are typographical errors in your book. Got the picture, I think, right? And so when we talk about gene mutations that cause or predispose to disease, that's really what we're talking about. And so to the question that was asked earlier, we know which chapters to look in, right? Because we've actually discovered which genes, or many genes, predispose individuals to develop heritable, as Dr. Austin said, pulmonary arterial hypertension. And if we know already a family with a specific mutation, meaning we know, the exact typographical error in the exact sentence, we know exactly which page to go to and where to look with our genetic testing. But if we don't, then we might test, panels of genes that we know cause the disease. So we might only look on, page 35 in chapter 2 plus page 42 in chapter 4, looking at the exact known genes known to cause pulmonary arterial hypertension. So having said that, one of the questions I'm going to try to answer, I hope you'll all be able to take this away when I finish, is if you have a family with, as Dr. Austin said, 2 or more affected individuals, what genes might we look at if we have no, clue what gene is causing their disease? And the first gene that was discovered and recognized to have mutations that were causative for this disease was the so-called bone morphogenetic protein receptor type 2. So that's a big medical mouthful. But all it's really saying is this gene, this sentence, codes for a protein that was previously known to have something to do with bone growth. I mean, think about it. Isn't that amazing that we would discover that a disease of the pulmonary arterial circulation was caused by a receptor on cells that previously in biologic laboratories was known to affect bone growth, right? You wouldn't intuit that. And now the key point for all of you just to know is that we think that about 80% of families who have PAH, so if there's 2 or more individuals affected, roughly 8 times out of 10 we will find a mutation in the gene that codes for BMPR2. So that's the predominant genetic cause of familial or heritable pulmonary arterial hypertension. Then there are some lesser actors, right? Some less frequent genes that are known to cause pulmonary arterial hypertension, but they constitute another 10% or so, and I think Dr. Austin said this as well. There are still some families that we haven't found, the rare genetic cause for, but let me just list for you, if you're interested, some of the other known genes. There's a potassium channel gene, we call it KCNK3. There's a gene that Dr. Austin and his colleagues first reported called caveolin, which has to do with enveloping things inside of a cell. There's a SMAD protein which is on the pathway of the BMPR2, SMAD9, so it makes sense that that would be part of this whole process. And then there's another pair of genes that cause pulmonary arterial hypertension in patients who have pulmonary arterial hypertension combined with another rare heritable condition called hereditary hemorrhagic telangiectasia, or HHT, we call it for short, right? And those two genes are called ALK1 and endoglin. So now I hope you can kind of picture that if we are confronted with a family that looks like they have HHT and PAH, we might reasonably do a panel that looks at endoglin and ALK1, because that's, it's, how many have ever heard of Willie Sutton? Nobody? Judy? You've heard of Willie Sutton, right? Willie was asked, why did he rob banks? And what was his answer, Judy? That's where the money is. So, we do our testing in this, Dr. Austin talked about a big genome. We do our testing where the money is, where we already know to look. And believe me, when you're dealing with a book that has, I'm making the number up, how many thousand letters in that book? And you said
46 chapters.
46 chapters. It really pays to look. And by the way, that's the reason the testing can be so expensive if we don't know where to look, and so inexpensive when we know exactly where to look, just as an aside. Now, I want to mention two more disorders, and that is very rare conditions that look a lot like pulmonary arterial hypertension, and the two are called pulmonary capillary hemangiomatosis, or PCH for short, and pulmonary veno-occlusive disease, or PVOD for short. Recently, the discoveries were made that a different gene called EIF2AK4, eukaryotic initiation factor 2 alpha kinase. Isn't it fun to say all these words, right?
You said that well.
You like that, right? But another gene called EIF2AK4 mutations, different chapter, right, in the book, codes for a totally different protein and different pathway. And if you've been talking around the conference, you probably heard some people say, when we make these discoveries, they give us pathways that will, we think, eventually have therapeutic import. But EIF2AK4 is likely to be very helpful for us with these two rare conditions. Why? Because therapy and diagnosis can be helped by just doing the genetic testing. So this is important, new pathway. We can make a diagnosis with the molecular testing, sometimes without having to do a lung biopsy or other things. And we know that certain aspects of treating patients are influenced by which diagnosis we make. So this has become a very important discovery and advance in the field. And again, it's a different chapter. So put down EIF2AK4. Now I have a couple of other tasks in the time that I have, and I'm going to be a little faster, I think, with those. One important point that I'd like all of you to take away, if you or someone you know at the conference was diagnosed with idiopathic pulmonary arterial hypertension, not associated with scleroderma, etc., there's roughly 1 chance in 10, some might say 2 chances in 10, so 10 to 20% chance that is really the first individual affected with heritable disease. So if you follow that, what I'm trying to say is you're diagnosed with HPAH, there's roughly a 1 in 10 to 2 in 10 chance that someone else in your family will be diagnosed with this disorder in the future. And that's, important. And, that's where counseling and testing come in, and you're going to hear more about that. In fact, as many heritable cases present as the first case diagnosed as idiopathic as present with a second or third family member, okay? A couple other points that I want to make. What's the chance that you'll inherit this disorder? Or let me try this another way. What's the chance if a mother, for example, has a mutation that her child will inherit the disorder? For all of the PAH mutations, which we think are autosomal dominant is our term in inheritance, that means the child's chance of inheriting the mutation, of getting the typographical error that can cause disease but doesn't always, as Dr. Austin pointed out, the chance is 50%. So it's literally half the time that child will have a mutation that can cause the disease. And the last thing I think I want to say, I want to say one more thing. I mentioned EIF2AK4. The inheritance pattern for EIF2AK4 is different. We call that autosomal recessive. So what that means is that if the mother has the disease, for example, they have 2 mutations, because really the book is it's a little harder to describe this, but it's duplicated. So you actually have 2 sentences that have to be interpreted at the same time. And so the mother has to have mutations, or the father, in both genes. Therefore, they can only pass one onto the child, which means the child can only be a carrier. They will not develop the disease unless by the ridiculously and infinitesimally small chance the other parent has this rare mutation. So in autosomal recessive, the risk of inheriting the disease when both parents in our language are carriers, meaning they both have a sentence that would code for the problem, neither of them have the disease, but they're both carriers, then that child gets both the mutated genes, then the child gets it. That risk is 1 chance in 4 of inheriting. So for EIF2AK4, it's different than BMPR2. BMPR2 is 50-50, EIF2AK4 is 1 chance in 4. Last interesting factoid that has all of us focused, Dr. Austin especially has done some wonderful work in this area, is if you inherit that BMPR2 gene as mutation, as he's already told you, not everyone gets the disease. We call that incomplete penetrance. In other words, you can have the mutation and in a whole lifetime never develop the disease. Well, guess what? If you inherit the mutation and you're a woman, your chances, as best we know it, are around 40 to 45%. So it's almost a 50-50 for a woman who inherits the mutation, whereas for a boy, a male child, the chance is way down around 10 to 12%. So there is a gender risk that goes into this as well, and we're exploring that because if we can understand that, we might make a difference too. I've said more than enough.
Thank you, Dr. Elliott. That's fantastic. Does anyone have any specific questions for that? And we're going to have time at the end for questions too. Yes, ma'am. Vagabond
We
Betty.
need to ask questions in the microphone so it can be recorded. So I will come over.
I'll repeat it.
Oh, that'd be good.
Excuse me?
I said if she asked, and
You can
I think I'm
repeat.
off. I'm not sure I quite know the question, but I understand. Who, help me again, I'm sorry. Your sister has the disorder. Yes.
And I have another sister that gets tested for it, but she's got Sjogren's and scleroderma.
So just so you know, those we would call, thank you very much. That's an excellent question. So for the audience, This is a family where another sister has the disease with scleroderma and Sjogren's disease. We call these associated, and when we've looked for the mutations in the common genes like BMPR2 in those conditions, we almost never find them. So we don't, I would say, if it's related to, associated with scleroderma, et cetera, there may be a totally different genetic predisposition, but it's not the genes that we're talking about.
So that wouldn't be what would be passing on maybe to my granddaughter?
If there's a, yeah, so the question was, could I be passing this on to a granddaughter? I think you started by saying you're unaffected by this disease, but you have a sister who's affected, 2 sisters. So hearing that, it's pretty complex for me, and I'll let the other panelists jump in. When I hear 2 sisters, and that's all in a family, in my language, that could be either an autosomal dominant, like a BMPR2, but it also could be an autosomal recessive, even like EIF2AK4. So your situation is a little bit complex. But yes, you could be a carrier of a mutation, particularly if a grandchild or child has it, who demonstrates what we describe as incomplete penetrance, meaning you never develop the disease in your life. But I choose my words carefully. Could be, maybe. We're not certain at this point.
Because I also have some distant cousins, that's why I'm here. I'm here with some of my cousins that have it.
Yeah.
That sounds good. Well, maybe Betty, if it's okay with you, we can talk to you after about the specifics, because that's important, and thank you for sharing that. But in the interest of moving forward, maybe that's a nice, actually, foray into my colleague Lisa Wheeler's discussion about the genetic counseling testing. How does that work with clinical and research differences?
Right. So, thank you all for inviting me to be part of this panel. I want to talk a little bit first about research samples versus what we call a clinical sample. So a clinical sample is when you go to your doctor and he or she wants to check your chemistries or your hematologies, and they send it to the laboratory in the hospital. That's what we call a clinical test. So in the genetics world, there are research samples and there are clinical samples, and they're different. So here at the meeting, you guys are providing lots of researchers with research samples. And I want to really reinforce that because a lot of times you are going to be disappointed because you may think that you'll get some kind of result specific to you from that sample, and you won't. And there's lots of reasons why that happens. One is, by law, a research laboratory cannot provide results to patients because it's against US law, and we can get in a lot of trouble for that. Also, research labs don't have the same stringent quality controls that a clinical laboratory has. So when you give a sample, especially something that's pertaining to your genetics, you want to make sure that it's in a lab that has the most stringent quality control and can legally provide you with a result. So I always start this out with, I gave you a sample already, is what I hear from our patients. Like, why do I have to do it again? Well, that is why. So even if you kindly give a research sample to any of the researchers in the room today or at any other conference, you will definitely have to provide a new sample for a clinical confirmation of anything that's found in a research laboratory. So I just want you to be aware of that. In a lot of ways, one little clue I usually give to patients that call me and ask me about it is like, if you didn't pay for it or your insurance company didn't pay for it, don't expect a result. That is an easy way to remember. If you paid for it, your insurance company paid for it, then by golly, you better get a result. So that is one reason why you will oftentimes be asked for another sample, particularly when we're talking about genetic studies. So what's the process if you wanted to have a genetic testing done in a clinical laboratory? Your physician would refer you to a genetic counselor. a genetic counselor is trained to help you understand this process and what are the risks and benefits of learning this information, because there may be aspects of it that you haven't thought of, or even your doctor hasn't thought of, that may make you think twice about pursuing this. I'm not giving you an opinion about what I think you should do, but I'm just saying it gives you a chance to think through what are the consequences of learning this information, and is it the right thing for me? And that is their job. That's what they do. They will draw a new sample if you choose to pursue testing, and they'll send it to one of the laboratories around the country that does this testing, because it's not done at every single hospital all over the country. There's only a few centers that do. Getting to the point of directed testing, like, likely in a family that has more than one person affected, we might direct that towards BMPR2 testing. But if we're really not sure, or if you're an idiopathic person, we might send it to a lab that offers what we call a panel. So they test more than one of these genes that has been discovered already to cause the disease. And so just to make sure we cover all the bases. So the results will come back to the genetic counselor. They will call you back in to meet with them and discuss the result with you. And they'll help you work through that process, because even people who get a negative result sometimes have problems with that, and that's described as survivor's guilt. Sort of like, oh, my mom had this, and my sister had this, and my brother had this, and why was I spared? And you might think that sounds a little odd, but people actually do have problems with that. So another issue, if you get a positive result, is we really, even though you get that positive result and you're an unaffected person in a family, it does not tell you if or when you will ever develop the disease. So it gives you information that you might be more careful about your clinical monitoring, like you might go more frequently for echocardiogram to screen to make sure that you're not developing the disease, because as we know, as all of you know, it can take a long time to get a diagnosis, because you can have very subtle symptoms for a long time. If you got a negative result, then you could stop that screening. And it can also, there are reasons obviously why you'd want to know this, because it might help with your family planning, it might help, with even where you get a job, or there's lots of reasons why you may or may not want to pursue the testing. But I did want to make that point, is it doesn't predict if or when you would ever develop disease. And as Dr. Elliott mentioned, for women, the risk is a lot higher than it is for men. It's one of the things that we are trying to understand why that is, and Dr. Austin's actually doing a lot of research in that area right now. Make sure I've got to check my cheat sheet here, make sure I covered everything I wanted to say. Oh, the other thing I wanted to mention, because a lot of people are concerned, there was a law that was passed several years ago called the Genetic Information Non-Discrimination Act, which is both good and bad. It will protect you, your health insurance, and your employability if you are found to carry a mutation that gives you a predisposition for disease. But it does not protect disability or life insurance. Why they didn't do them all at once, I don't know, but that's just something to keep in mind, because a lot of people are concerned about that when they start pursuing this kind of testing, is it going to affect my life insurance, my health insurance, and by law it should not, and they can't drop you and they can't raise your rates. So there's just something to keep in mind about that. And I think that comes to the end of my part of the session.
Super, thank you. So why don't, thank you. Next, we're going to talk about research, but are there any specific questions related to what Lisa said that are burning that you wanted? Yes, ma'am. What does it cost to do genetic testing, Lisa?
I can't tell you exactly, because it's different at every different clinical testing center. It is less expensive if you know, for instance, if you're in a family that has multiple people affected, and an affected person in your family has already been tested, and they do have a mutation in BMPR2, let's say, so we know the specific mutation to look for, then your cost is much less, because when a sample is sent, say, from you to the laboratory, they'll know exactly which mutation to look for. So they're not screening an entire gene, they're just looking for that one little. So it's much less expensive that way. So, it varies a lot between different laboratories. So unfortunately, I can't give you the answer to that question. But that is something your genetic counselor can help you, can find out for you. And other people may ask, I didn't address this, but some insurances will cover this kind of testing and some will not. So it's something you would need to ask your genetic counselor about, have them investigate for you before you pursue it.
Yeah, I've really been impressed in the last few years. There has been a change in our clinical experience for the children, is that more and more insurance is covering it, but as Lisa said, you cannot guarantee that. So that's part of your careful consideration, and you can actually talk to your insurance in advance and see if they would cover it. So why don't we bring in Dr. Micheala Aldred, who's been studying the intricacies related to genetic and cell-based changes associated with the mutations that we've been discussing and the concepts we've been discussing now at the research level. What is being done, what has been done, and what is coming? Thank you.
Great. Well, thank you very much, Dr. Austin, for inviting me to join the panel. So as he said, I'm going to switch gears a little bit and just tell you more about what research has been done, what the previous research has contributed to our current knowledge of pulmonary hypertension, and then what kind of studies are ongoing now and like where we're going in the future. So Dr. Elliott mentioned the first gene that was identified where we found alterations that cause pulmonary arterial hypertension. That was the bone morphogenetic protein receptor 2, and that's a big mouthful, so we call it BMPR2 for short. And he told you that about 8 out of 10 people who have familial PAH will have a mutation in that gene. And Dr. Wheeler and I and others at Vanderbilt and a number of other centers were part of the international consortium that first identified that gene back in 2000. So we've been studying that gene for over a decade now, and we've learned a great deal about when you have one of those typographical errors in the gene. We can study what the effects are on the cells. We can see how those cells behave differently. And the cells that we're especially interested are the ones that are in the vessels of the lung that are most affected by pulmonary hypertension. So we've studied them. We've learned what goes wrong. So we know what the gene is meant to do when it's healthy, when the cells are healthy. And then by studying what goes wrong when we have one of those typographical errors, first of all, it's allowed us to understand more about what's actually causing pulmonary hypertension in the families who have those mutations. And then once we understood more about the bad effects that those spelling errors have on the cell, then it's allowed us to go and look at other cases of pulmonary hypertension, often idiopathic pulmonary hypertension, where there may not be an error in the gene itself. But if we look at the protein, the things that come downstream of the gene, so the gene is the instructions and the protein is the thing that the cell is making from those instructions. So sometimes the protein is, it's not present at the right level. So even though the person doesn't have a genetic error, they still have some kind of effect on the BMPR2 protein. So by starting with the families who have those mutations, those spelling errors, we've been able to learn so much more about the disease as a whole. And now we're starting to get to the point where we are developing therapies, and I say we in the global sense, not just my group, but many groups across the country and around the world are focusing on that pathway to try and understand how we might be able to correct the defect at some level and have new therapies towards pulmonary hypertension. And I'm going to come back a little bit more to therapy at the end. So, it's a long process, but by studying families and starting with those genetic errors, the research eventually is accumulating just a huge amount of information that we can apply not just to the people who have familial PH, but to many other types of pulmonary hypertension as well. So all of you who have contributed to research over the years, you really, your samples are very, very valuable and creating a huge knowledge base that are helping us to understand pulmonary hypertension. And the same is happening for all of the other more rare genes that Dr. Elliott talked about, but because they were discovered more recently, we're still in the earlier stages of trying to understand how those spelling errors, what effects do they have on the cell, and we need to understand that before we can try and understand how we might be able to have therapies that are targeted towards that. So that's a little bit about how research in families can contribute to understanding pulmonary hypertension as a whole. The other thing that I wanted to talk about before we get back to therapy is just to tell you a little bit more about some of the other studies that are going on at the present time. So one of the major focuses of a number of groups, including all of my colleagues here at the table, is in the families where as yet no genetic mutation has been found. These guys are all working really hard to try and understand which chapter of the book and then which down to the page and even the sentence within the book, where are those other typographical errors that are causing pulmonary hypertension in that family. And it becomes harder and harder to do that because they have a lot of letters to be working through. Even if we just look at the genes, they have to look at I think it's 30 million letters to try and find out which one has an error. If we look at the other parts of the genome that are not immediately coding for a protein, then it's actually 3 billion letters in total. So it's a lot of work to do that. It's expensive, but the technology has really improved so much in the past few years that it's now actually feasible for people to do that. So that's one of the things that they're working on within families. And then there are many other studies, large collaborative studies in this country and elsewhere in the world, which are looking not just at familial PH, but idiopathic and some of the other types of pulmonary hypertension as well. And I just briefly wanted to mention one that some of you may be recruited into in the near future. There's a large collaborative study that's funded by the NIH. With some additional funding from the Pulmonary Hypertension Association, so they're directly involved in funding one of the centers for this. And this is a study called PVD omics. So the PVD stands for pulmonary vascular disease, and the omics is, you might hear that term, it's kind of like, it means kind of like everything that's going on in our cell, not just at the gene level, but at the protein level as well. And it's going to be a very, very big and ambitious study. In Cleveland, we have the Data Coordinating Center. Vanderbilt is one of the 6 clinical centers that's involved in that. And if I try and list the other 5, I'll probably get in trouble because I'll forget one of them. But there are six of the large centers around the country will very shortly be enrolling patients with all kinds of different types of pulmonary hypertension. They will be doing some very detailed clinical workup to get as much information as we possibly can. And then there will be some blood samples and some urine samples to try and analyze all of the different things that we can at the, in the cells and in the circulating blood. To try and then put together this really big study to give us a much better understanding of how pH is classified, and hopefully that is going to give us new clues as to how we might start developing treatments. And there's also in the UK a very large study where they're actually doing DNA sequencing on the majority of the idiopathic patients within that country. And at the American Thoracic Society a few weeks ago in San Francisco, a group of us got together from many different countries. So there are a number of centers from the US, from Canada, from many different parts of Europe. And we're all starting to talk about having a big international consortium so we can really, all of the money and effort that everyone is investing and all of the samples that you as the patient community are contributing, we want to make sure that we can really maximize all of the information that we get from that. So it's early days to get everyone together, but we're really, I want to emphasize that we're very much working to the same goal and collaborating with each other. So just to briefly talk about therapies and how this research is helping us. I know in the bullet points that we had in your brochure, there were a couple of different questions. So can we modify genes was the first question. And the answer is yes, potentially in the future we might be able to do that, but it's still, that's still a long way off. So there are some groups that are looking at what we call gene therapy, which is to try and put back the normal gene to kind of overpower the spelling error and try and make the cells go back to normal. So there's been some very promising studies in animals, but it's still quite a difficult thing to do, and there's a lot of safety concerns that have to be addressed before that's actually going to be used in humans. So that may be something that comes in the future. And it's definitely something to watch, but it's probably not going to be immediate. And then, you would think that if we could actually go and take that spelling error and put it back to normal, kind of like, use your correction fluid and kind of like white it out and put back the correct letter, that would be wonderful. And that's actually, it's not completely science fiction. We are developing therapies that actually can make changes to the genetic code. It's been done in animals, and we do it in human cells that we have growing in the lab. It's a little way before we can really try that in humans, because at the present time it's not very specific. So, we know that we want to target this particular gene on this page, and we need to change that letter, but at the moment we don't know how to control it well enough. So we might have other errors that crop up in other places, and we certainly would not want to be changing, correcting the gene that's causing pulmonary hypertension, but then something bad happens elsewhere in another gene. But perhaps in the future, when we can have a better understanding about how to control that, maybe that might be something that we can do in the future. So I don't want to raise your hopes too much. It's just to give you a sense of some of the very exciting things that we are at least looking at. The things that's going to be much more immediate in terms of therapies that are targeted towards some of the genes that we've found they're going to be what we call small molecules. So it's just a drug that you take either orally or you have an injection, similar to the kind of drugs that many people are taking right now. And they're targeted to the particular signaling pathways that we understood by looking at the genes. So especially the BMPR2, because we've been studying that for the longest period of time. There are a number of different ways that we might be able to either raise the level of normal BMPR2 so it functions better, or we might be able to do something else to try and improve the signaling and get it a bit more back to normal. That's something that we're seeing a number of very promising therapies from different groups. And I'll just mention a few that are working out on that. Stanford University and Dr. Rabinovich's group are doing some studies there. My own lab is doing some early studies to try and correct a particular type of genetic mutation within BMPR2. Dr. Morell's group in the UK is also looking at this kind of thing, and a number of other groups as well. So some of those therapies are still in the research phase, looking at animal testing. Some of them are actually getting to the point where they are beginning clinical trials as well. And I think another gene that was mentioned, KCNK3, is also one where there's already a drug that's potentially targeting that pathway. If it's a drug that's already been through phase 1 testing, is known to be safe in humans, maybe it's being used for some other indication, that means that it's much, the ability to repurpose it and use it in pulmonary hypertension is much easier, which is not to say it's easy, but it's certainly quicker than coming up with a brand new drug that needs to go through all of the safety testing. And these drugs, the things that people are looking at in relation to the pulmonary hypertension pathways, some of them are already at the point where they are doing some initial clinical trials in patients with pulmonary hypertension. So I've said an awful lot, and I want to give you plenty of time to ask questions, but I hope that gives you just a snapshot of how your research samples can contribute to our understanding of PH, and hopefully where we think we might be going in the future with therapy.
Oh, that was a beautiful overview. Thank you. Thank all three of you for wonderful overviews. I think, yes.
We have a question over here.
Great. I thought, Juliet, maybe you and I could go around and play Oprah, and we'll do questions, and then we'll lock the doors and take the test.
Yes.
You guys brought pencils, right?
Did you have a car ready?
Hi, yes, through reading I'm starting to understand more about how pulmonary hypertension patients might have different levels of expression in different cell types, and so you might have an overexpression in an endothelial cell and an underexpression in a smooth muscle cell. And I guess I'm curious as to, are we at a point where we've started sort of harvesting those cells from people and trying to look at that in individuals? And if we're not, are we going to be there? If somebody's doing it, who's doing it? Do we need to be there? Those type of questions.
Looks like we all pointed at Dr. Aldred for a reason.
So that's a really great question, because I think, one of the big puzzles that we all struggle with is why is pulmonary hypertension mainly affecting your lung tissue and not so much for the rest of the body? I mean, I think we understand now that there are effects on other parts of the body as well, but it's really the lung tissue that's the primary target. So you're absolutely right. The endothelial and smooth muscle cells in those blood vessels are the major focus. So are we isolating those cells and being able to study them in more detail? Yes. So there is another network that I didn't mention, but it's called the Pulmonary Hypertension Breakthrough Initiative, which has been running for probably about 8 or 9 years now. And again, Vanderbilt and Cleveland are two of the centers involved in that, together with Stanford, Baylor, Allegheny, UAB, Michigan. And so when patients are on the list for transplant at one of these centers, they can be consented so that when they have a transplant, if they're willing to donate their lung tissue to research, then we can actually isolate those cells from the blood vessels. And we and many other groups have been studying those cells to try and understand the kind of question that you asked. And again, I want to emphasize that that's being done as those cells are harvested as a resource for the entire community. So they are in a bank at Penn, actually. And other researchers can apply to receive those cells and to be able to study them. So that's been a really great advance in our understanding of pulmonary hypertension, what exactly is going on in the lung. And once we understand that, then we can try and go back to some of the blood cells and look for circulating markers and things that will help us in the majority of patients who don't have a transplant. So I think many of the things that we found in the lung tissue that's so precious, now with PBDomics and with many of the other studies that people are doing, we can try and understand whether we can see some of those markers in the blood as well and develop new approaches. So thank you. That was a really great question.
Yes, ma'am.
Thank you. So, wow, this session has been the hardest for me to get my head around. So I'm going to try and vocalize this as best I can. Given that a gene is passed on and it's an exact copy, and it has been for years, for generations beforehand, and given that really in the last 15 to 20 years prior to this we didn't have the experience and the knowledge that we have now about the disease, would it be fair to say that there could have been that gene or that mutation or whatever in the family for hundreds and millennium of years, and it may just come out now, or it may just be found now? Does that make sense? Okay.
That's a great question. Dr. Elliott's going to help us with that one.
I'm gonna try, and then others. You heard the question, which is, could the gene have been around for a long time, and and not be known because we haven't made these discoveries. I do think, so first, of course, genes are part of our makeup forever, the human makeup, and animals too. In fact, we knock them out in mice to try to understand, what disease is caused when a gene isn't working. So that being said, it's a great question because it allows me to make a point. Sometimes people develop disease that's heritable based on what we call a spontaneous mutation. And I didn't mention that before, but the concept is pretty obvious. Both parents actually have normal sentences, the words are all spelled correctly, and somewhere in the passage of that DNA, there gets to be a typographical error, so the child shows up with heritable disease. So it's entirely possible for someone to have heritable disease that represents a spontaneous mutation, and it doesn't go back generations at all. The flip side of that is most heritable disease does go back generations. And what makes this sometimes tricky, a number of things make it tricky, but is the incomplete penetrance concept, wherein we call the individual an obligate carrier. So the mother has the mutation. The sentence in her book is an error, and it instructs the wrong code of the protein. But the mother or the father never develops disease. So you don't know it's there because it's back, several generations, and it came through that obligate carrier until suddenly the disease pops out again in a child or a grandchild. And part of the work that Lisa did so well at Vanderbilt for years, and this was really a life's work. You all need to appreciate what this lady to my right contributed to all of us. It was building those pedigrees out so you could see, this dark thread find its way through when it, again, there were skipped generations because of obligate carriers and incomplete penetrance. And then there are some other barriers too that I'll just quickly mention. One is, our nuclear family size. If you think about it, you can see, genetic disease when you have, a family with 10 children, it's likely to show up. But when you have one child, now you start skipping a lot because there's the likelihood is only 50%. If that child doesn't get it, or express it, you don't see it. And that's especially true for the EIF2AK4, which in our language is autosomal recessive. And therefore it takes one abnormal sentence from each parent, to come together so that the child has two abnormal sentences coding for the protein. And one aspect of that that's subtle, but when we look globally, oftentimes that can reflect as other autosomal recessive disorders, that can reflect inbreeding in families. And so, that's where these autosomal recessive disorders are more commonly seen, because the likelihood of the two abnormalities coming together is stronger.
I can give you a quick example of what you're talking about. I have sometimes, we've been collecting families for more than 30 years at Vanderbilt. So, and we do look for mutations in those families. And I had two families that I recognized that some of their ancestors had come from the same county in a particular state. And they had the same mutation, but they weren't obviously related to each other. So I actually had, with help from the families, we went back all the way to 1790 before I finally found the person who connected those two branches of those families together. And of course, nobody in those past, obviously, we couldn't even diagnose the disease until 1951, which is another issue. I mean, it was recognized before that, but we did not have right heart catheterization until 1951. So yes, the answer to your question is yes, it can be way back in the family history, but it is hard to discover that because of incomplete penetrance, because of the fact that patients don't get diagnosed, or they were not able to be diagnosed when you would go far enough back into the family history. So it's just by a lot of hard work with the families before you can kind of figure some of this stuff out.
It's really amazing what she does. She can go back generations. It's spectacular. We, Juliet just gave us the 1-minute call, so maybe we have time right quick, and I'll be happy to stay after. I can't. Perhaps some of our colleagues can as well. Oh, unless someone's coming in. Is there another session coming in? Okay, we'll hurry up.
We can meet out in the
One
hall.
more, though.
Well, my question is, I know that it can be determined through testing, but how likely is it if my father passed away of COPD and I have 2 siblings who have pulmonary embolisms and they're on medications for that, and I have hypertension, pulmonary hypertension, how likely is it familial? Is there, any way of telling without testing, or we definitely have to confirm it through testing?
You know, I'd say one way to think about that is that it's complicated, like Dr. Elliott was saying for Betty's case. But the COPD, the fact that you said you have 2 family members with COPD, 2 with pulmonary embolism. So you're talking, unfortunately, I'm sorry your family's been so affected. Right off the bat, you're talking about conditions that may be occurring pulmonary hypertension that may be occurring secondary to other challenges such as pulmonary embolism or COPD related to smoking or not. In that setting, it's certainly possible that you could have familial disease, but it's far less likely than the setting of a family that would have several people who have what basically looks like pulmonary hypertension for no other reason. Does that make sense? So it's conceivable that you have some family risk upon exposure to smoking and COPD, or upon exposure to clots that would be higher than the larger population, but not in a way that we could currently detect. So we could talk more privately to give you an opportunity to think about that. But upon first glance, unless you all disagree, I would think it would be less likely that you have a familial risk in the sense of what we've been talking about now in terms of specific genes that we know about. That seems okay. Well, I'd like to thank all of you for coming. I know we're cut on time. I'll linger out in the hall because I think that Juliet said we have another room. I want to thank our esteemed panelists. These are people who've put massive effort into the disease. And I want to thank you all, because this doesn't happen without you, and we're thrilled that we have so many people here and happy to chat and be whatever resource we can.